We're right at the top of the hour, and I want to welcome you to Take 10, Transforming Care for Women with Substance Use Disorders and Their Families. This is the third topic in our series, and it's considerations for male clinicians treating women with SUDs with Tim Devitt. This presentation was prepared for the Great Lakes ATTC under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, or SAMHSA. The opinions expressed in this webinar are the views of the speakers and do not reflect the official position of the Department of Health and Human Services. The ATTC believes that words matter and uses affirming language to promote the promise of recovery by advancing evidence-based and culturally informed practices. A few housekeeping items for you. If you have issues that are technical in nature, please reach out to us in the chat section at the bottom of your screen. Alyssa is not with us, but I'll be here, Rebecca Buller, and we've got Jean here as well, and we'll take care of those technical issues. Questions for the speaker, if you could please put those in the Q&A section at the bottom of your screen. That way we won't lose them. We're not sure that we'll have time for all of them. So we'll maybe try to circle back and send some responses via email. And your certificates of attendance will be sent out through the email to all who attended the session in full. Now, if you want to know more about what we're doing or what's coming in the near future, please check out our social media pages. And I'd like to take this moment to introduce our presenter. Tim Devitt is a clinician, trainer, consultant, researcher, and executive leader with 35-plus-year commitment to providing recovery-oriented services to individuals, families, and organizations. He currently operates a clinical therapy and consultation practice in the Chicago metro area with a specialization in integrated mental health and substance use care for adolescents and adults. And I'm going to turn things over to Tim at this time.
Thank you, Rebecca, and thank you, Great Lakes ATTC, for inviting me to present today. As Rebecca shared, I've been doing this work, it's now 36 years, and my background is as a clinician working with people that have, women that have substance use disorders, and men too. Has been in primarily earlier in my career as a case manager, doing crisis stabilization work, doing homeless outreach, program director for a large permanent supported housing and integrated dual disorders treatment program. And then, for the last several years doing more individual therapy with men and women and adolescents who have substance use and co-occurring mental health conditions. And what I'm wanting to What I'm wanting to cover today, or at least as I was preparing for this talk, I reviewed some of the prior presentations that are part of this series, and there's a lot that is there regarding, interventions and treatments for women. What I wanted to do is emphasize some of the recovery-oriented principles and trauma-informed care that are important for male clinicians to emphasize. And the goal is here to kind of bring to life some of these principles that are especially important for males by sharing a case, a clinical vignette. And it pertains to my role as the director of a large integrated dual disorders treatment permanent supported housing program, where I was the director and also the lead clinician. All the people that moved into this residence had to meet the HUD definition for chronic homelessness as well. And but what I'd like to do is to just take a few moments and introduce the clinical vignette and then talk about the principles of recovery and trauma-informed care that are important for us all, especially male clinicians, to recognize and keep in mind. But this particular client is somebody that I had worked with to move into the program. Process usually took a few weeks, maybe even a little longer with wait lists and everything. But on this particular day, it's move-in day for this person, and we'll call her Esther. Um, it's not her real name, but I'm working in my office, which it's an urban setting. My office is in the front of the building, and the sidewalk is around the other side of the window, and then the street. And so I hear all this yelling going on, and from my office, and it was her, it was Esther, who was moving in that afternoon. And what happened, the program van had gone to an abandoned building where she was staying and helped her to move in her belongings, and they were unloading the van, and there are boxes and boxes on the sidewalk and everything. And one of the boxes, actually a few of the boxes, had roaches coming out of them, and like bug roaches. And the staff had some concerns about her bringing those into the building, and stop the process and let her know that they were concerned about that. And that's where the yelling ensued. And to give you a little bit of background, this person had been homeless for several years, had cocaine use disorder, bipolar disorder, had not used typically, we may see people using during adolescence and early adulthood, but this person had started a family, had a number of children, had worked um, uh, in customer service, doing phone work, and was in a relationship with male where cocaine was introduced, started using the raw cocaine to the point where it became an addiction. Decided at that point to move away from the family. The oldest child, who was late teens, took responsibility for caring for the younger children. Her mother, who is now in her late 50s, early 60s, stepped in and became the primary care provider. And she was gone for several years, living, you know, with this particular person. And then when that didn't stay, when they no longer stayed together, was living outdoors or in this homeless situation. Um, and But I mentioned that she was yelling, and so I went outside, and basically he started cussing at me and was telling me that, we had no right to deny her accessing the building with her property. It was her legal right, everything. And I agreed, that this was her property, and we wanted to figure out if there was a way to help her move in, but also deal with the roach problem. And I asked if there was a way we could, or if it was possible for us to address the roach problem and then bring the boxes in. Um, and she was willing to talk about that, and we came up with a solution. I'm not saying this is the only solution or the best solution, but in the spot, in the moment, it's what I came up with. And I said, we could take their shoes in these boxes. There were about three of them. They were about 3 feet by 3 feet high, almost waist high, 3 feet wide, 3 feet high, and it may be 50 pairs of shoes in each box. There were so many shoes, and this was all. That's all that was in these boxes. And so they agreed. They agreed that we would wipe off, put them in a new box and take the shoes out. That if there were boxes, if there were shoes anyway that we could get the roaches off of, we would put them in a new box. But as we started digging into the boxes, there were more and more roaches at the bottom. And so she agreed at that point that we could use a utility shed that we had alongside of the building for tools, and we would put the boxes of shoes that were heavily infested at this point. In there, and we would get them some foggers, and we would take care of that over a day period. And then we agreed we would help her clean off those shoes that were, that had that residue on them from the defogger. And we had to go back and forth and come up with a plan that worked for her, that she felt comfortable with. But we did that, and she agreed to that. And she moved in. She moved in that day, and the next day brought in the majority of the shoes. And I'm going to kind of then talk through, for a good part of the rest of our time, talk through her movement and treatment, and what was important for us to consider, and how it ties back to some of these recovery-oriented care principles and trauma-informed care principles. Um, the program had a very comprehensive approach to treatment, again, using the integrated dual disorders treatment paradigm. Um, where you look at people based on, you work with people based on their stage of change, and offer a number of evidence-based practices, including, CBT for addressing substance use, motivational interviewing for earlier stages of change, a number of 25 some groups, a number of different things that we had offered. A lot of us sort of in reach, we called it, where we would do, it was an outreach because they were in the building, but we did a lot of practical assistance, helping people to manage day-to-day stressors, housekeeping, managing apartments, tenancy, things like that. And what was typically important is to engage people in the process of developing a personal recovery plan and treatment plan goals based on recovery, focusing on jobs, focusing on education, focusing on mutual aid, 12-step work, whatever it was, multiple pathways, but really putting together a tight plan. And what was interesting with Esther is that, she really didn't want any part of that. She was not interested in engaging in the program much at all. But what was important is that she was interested in addressing these 4 dimensions of recovery that we now understand are endorsed by SAMHSA in important foundational dimensions really for recovery. And and that's the first one being home and having a safe place to live, and having a stable place to live, and that became where she stayed, for a good 3 years, this apartment, and really turned it into a nice home. Decorated it, cooked a lot of great meals there. But those first few weeks, we didn't see much of her. She would come in, leave, go to the grocery store, come back, could smell some good food coming from the unit, but really was not interested in connecting much with people. But what started to happen is over time, she became more interested in accessing some support from the staff to address healthcare needs. Wanted some help accessing with the doctor, getting Medicaid set up. Um,
Jean, did you want to share your slides? Sorry to interrupt. I just
are my
finished sharing.
are my slides not showing?
No, sorry.
Oh, I am so sorry. I thought they were. Okay.
No, that's okay.
All right. Let me get this going here. Huh. Okay. Um, there we go. You got these now? Can you see these?
It's just coming up. Hold on. It's all black on my screen.
Me too.
Oh, we just practiced this too. Is this showing up now? Can you see them now?
No.
No,
All right.
still black.
Huh. Well, would you be able to put them up and we can just advance them then? I don't want to take any more time let's see, I'm going to try this one more time. Okay. Is that?
There they are. Yep.
Okay,
You can
good.
see them.
Okay, good. All right. Okay. So I've basically kind of covered the first steps here, and I'm getting into now what are the 4 dimensions of recovery that endorsed by SAMHSA, and just sharing that, for Esther, this became what was important to her, and she guided this, through her own, self-determination, wanting to have a safe place to live, wanting to address healthcare over time. For her, the purpose activities really involved trying to reunify with family and strengthen relationships that had been neglected. Not so much with her children, but more with her siblings and her mother at first. We later learned that she was connecting more with children, but that happened much later. And then also building a relationship with some of the peers that were in the building and becoming very active in a local NA meeting that was in the neighborhood. But what I want to emphasize here is that, I'm a male clinician running this program, and, most of what we were focused on was engaging people, helping people engage in the process of recovery, and having some markers set up, like personal recovery plans, having, access to the services that we're offering from psychiatrists, from nurses, case managers, and for a long time that she was not really wanting to participate in much of that. But what did start to happen is that she started, through her own self-determination, asking for more of this support, asking for more of this help over several months at the beginning. And that was a big factor in this, is that we'll get into as we get into the recovery, these guiding principles of recovery, that we want to create an environment, or create a situation, understanding anyway that these principles are important in guiding recovery, and we want to be cognizant of what those are, but also really honor and emphasize this idea of being person driven, and that there being multiple pathways, and the importance of relationships and peer support and culture, addressing trauma, emphasizing strengths and respect. I learned a lot about how this experience went for Esther several years later, when they contacted me. So basically, they had discharged from the program rather abruptly after 3 years. They basically came in and said, thanks for having me here. I'm moving out in a few days. I have this invitation to come live near my daughter, who is living in a different city, and I need to be there, and I need to kind of work on this relationship. So they moved out. Didn't want help with referrals, didn't want help connecting with services. Said, I got it, I'm going to go. And it wasn't until 6-7 years later that I heard back from them. This time now they're back in Chicago, and they were interested in referring their son, who was a young adult at the time, to the same program where they had lived, and identified their son as having a co-occurring psychiatric substance use disorder, and wanted to know if they could refer them to the program. And so we talked for a while. I was no longer at that program, but I did what I could to assist getting them connected up with the intake there. And when I got back to her to let her know that, we talked for a while, and actually had a meetup, check-in, at the agency, where they shared a lot, and basically what they shared with me is that they had spent those last 6 years since they moved out in different cities, in different parts of the state and cities, spending about 1 year to 2 in each one, in close proximity to their children that were living in these different areas now as young adults or adults, and really working to reunify and repair the relationships. And they thanked me and the program for the help that they had received through the Permanent Supported Housing and Integrated Dual Disorders program. And let me know a few key things that I let them know, that I let Esther know that this was all about you. That you had been very self-directed and fully responsible for your success. And they thanked me still, and said that it was our ability to listen and not tell her what to do that helped her want to stay. They'd been in many programs before and hadn't stayed, and said that the one thing that they felt was respected, and noted that it went a long way in helping them to have some hope, and helping them to not give up. And they even shared that the program had become a family when she didn't have one, and helped her to have the courage and confidence that she needed to start getting back with her biological family, first with her siblings, then her mother, and then after transitioning with her children. And she said that they were very angry with her, and that they had a right to be, and that she needed to be ready to assess that, and that our listening and that our support, not telling her what to do, but giving her, offering her an array of options, giving her choices along the way, and support, and falling back on those evidence-based practices that we did offer when she was ready, helped her to take these next steps with her family. And it was interesting because I recalled how, and she recalled too, how we had wanted to connect her with family. A lot of living there for several months, we never saw anybody come and visit. We're working in an environment where they're living. It was a residential program, so we could see it wasn't just an hour a week coming in for therapy, but it was pretty intensive. And we didn't see family there, but we knew that was a stressor, and that was something that she really wanted. And we offered that, and she said basically, "Oh no, I don't want any of that." But what she did say we did is that we helped her to be able to go address her family issues on her own, and but she didn't want it in her treatment plan. She didn't want it anything that we were, any family sessions or anything like that. But it came back to the respect issue, or the respect and the self-determination. And a lot of this, what we see here, these guiding principles about hope and being person driven, having multiple pathways, holistic peer support, relational approach, understanding the importance of culture, and how she needed to kind of move and work with her family. That all of that, is letting her guide that, and being and working to honor that became, from her report, critical. Became a critical part of what helped her to continue moving forward. I'm going to move on now to some of the trauma-informed care principles as well. Um, Safety, peer support, trustworthiness, choice, collaboration, empowerment, attention to culture, historical gender issues, and so although it's important to have evidence-based practices, it's important to have this recovery focus. It's not enough. Being trauma-informed is very important from the first contact through her transition. It was important. This slide speaks the importance, and it was important for us to work on it, paying attention to that, and trying to build that into what we did. I think for safety, it generally means maximizing control over one's lives. In substance use treatment for providers of residential programming, safety can often involve trying to maximize control over the work in the living environments, minimizing risks, establishing safety for the clients and also for the staff. But one thing that's important to emphasize with Esther is that, that she shared experiencing, again, was this respect, and how that could be therapeutic in and of itself. And clinical interventions with male clinicians that are person-centered and respect autonomy and agency can provide an opportunity for that male to be seen more as trustworthy, to be safe, and could potentially counter abuse-related dynamics that may have become internalized. So keeping that in mind, it was important for us to work on that with her, and the goal was to create a safe space. I think one other thing that I want to emphasize in a consideration is in terms of safety is addressing the trauma, the actual trauma, and the importance of offering to support her in addressing trauma, but making sure she knows it's not something she has to. There's no requirement to talk to us about it. There's no requirement to engage in exposure-based treatment for it. That we can offer non-exposure-based treatment as well, more CBT type approaches, or seeking safety, or building up skills. And I've got some material on that coming up, special in a moment, but wanted to emphasize that as well, as part of safety is giving people the autonomy to not have to address it if it's not something they want to do, or to do it in a way that's comfortable for them. With peer support, how we go about encouraging. We all know that peer support is essential. It's a critical component of care. But how we go about encouraging it is important. For this person, it became a very organic kind of. It built up organically for her. It was something that she initiated and connected with. We certainly had talked about the need for peer support, sober support, and building up a network of peer sober support. But how she went about it wasn't something she really wanted to discuss or include in her treatment plan. She just acknowledged that was something she would be willing to do. So it was voluntary, it's not judgmental, it was respectful, reciprocal, empathic. And I think what helped in residential programming, at least, was to see it in action, that we could see that she was engaging, just because we worked where she lived, and we could see her over time interacting with people, and having strong support. But I just emphasize it wasn't something that was, it wasn't a guiding thing that we emphasized. It was just ingredients were there, and she made use of it, if that makes sense. And I think for her, that was an important piece. And I think it's important for, males in particular to to recognize that it wasn't something we were requiring at all or making happen. It was just something that try and create the environment for it to occur, and it did. With trustworthiness and transparency, as a male director, it was important to make decisions and with consideration to the goal of building and maintaining trust with the participants. Some examples include being consistent, maintaining boundaries. One example I can give for that is hugging. It tends to occur in residential programs, treatment programs where there's a lot of hugging going on. I personally am not engaged in hugging with the participants, especially the women participants. If people, given substance use disorder trauma backgrounds, the prevalence of trauma backgrounds with the clients that do have substance use disorders, if they do want to hug, I'll give a gentle one, but I'm not the one to initiate it or make it part of what people do when they see me. But we can be affirmative. We can be very supportive in our daily interactions, of course. Adhering to the schedule for groups and appointments and visits, making sure informed consent is something people really understand, and that they understand their options. They understand what it is that is being offered. Directly addressing limits of confidentiality, advocating and seeing advocacy in action, and then promoting self-advocacy, being authentic. With choice, it was important for Esther to believe that there was choice. There was choice every step of the way, and I think that was conveyed, that she experienced that, and her notion of respect, and what she was saying that she experienced as part of being there. Collaboration is really important in that we're partnering and leveling the power differential between staff and clients. Esther had some concerns as they move forward and establish long-term recovery with some peers. That were also in long-term recovery. There was some concern about the impact of people who were struggling with their substance use, people in earlier stages of change. We're using the impact of that on the recovery environment, the impact of that on them and their recovery, and so they were beginning to say, this isn't right. We can't have people actively using in this type of residence, and we sought their cooperation or collaboration to help address this more. We began having, with Esther leading this effort, actually, we began having some Saturday morning breakfasts where, we would, program would buy the food and the participants would help preparing it, and we would sit and talk about the different issues that were going on and the impact that was having and how people can cope with that. All were welcome. And from that came this notion of having a peer support committee or a group of people who would, in long-term recovery, who would be willing to sit with the person who was struggling and offer suggestions about what had helped them in their recovery. And at the same time, share some feedback about the impact that the substance use was having on people who might have been at that early action stage of change, or people that were still struggling but trying really hard to not use, and became a very strong advocate for that program, and was very involved in that. But I share this as an example of trying to address an issue collaboratively, and as the male director there, working with them and supporting her in particular with her need to have some agency with this issue, but at the same time, do it in a way where it all benefited, hopefully. Empowerment, recognizing that we want to build, that it's important to build upon strengths and experiences there. Having a voice and choice, validating that. And recovery encompasses one's cultural background, embedded in values. And for me, I was regularly told what could be improved or what needed to change, and from Esther, and how we could do better at addressing the cultural needs of some of the people that were in the building. And I really saw this as a fortunate experience to be getting this feedback and being able to incorporate, partner to make it more collaborative and owning that which I didn't know, but at the same time trying to do more as a result of her sharing what she thought we needed to do. I want to just emphasize the importance of offering the non-exposure based treatment. There's some research here. I'm running out of time. There's some research here to support the need for non-exposure treatment. That there's some evidence to support that that exposure-based treatment can be very helpful for people with co-occurring disorders if they've been sober for 3 months. But I think it's important to look at who's included in these studies, and oftentimes people with examples of borderline personality disorder or suicide or who are actively using are not included. So what we do know is that the non-exposure based interventions that focus on developing skills, psychoeducation, seeking safety as an example, CBT, cognitive restructuring, that is important, and that we can start there often. So it's an important consideration. Inviting family in a way that was important for Esther, I think is really important, and that is helping her to develop the skills so that she can address that with family. Of course, we offered to include family, she turned it down, and it was grateful to know years later that how she went about engaging with her family based on what she had learned resulted in her reunifying with family members and especially her children. I have some examples here of integrated treatment for co-occurring disorders, evidence-based practices endorsed by SAMHSA. And these are all important. I think what's most important is just to emphasize, that recovery isn't a step-by-step process, but it's one based on continual growth. It's not linear. There will be setbacks, or there can be setbacks. We want to learn from those experiences. But most importantly, I want to just emphasize that male clinicians working with women can benefit from recognizing that recovery does not refer solely on changes in substance use. It's also about making changes in how one lives their life. And markers such as improved health, better ability to care for oneself and others, increased independence, enhanced self-worth are also great examples and important for progress in recovery. But what I've learned from my work with Esther and I think important considerations for males is to not be directive here, to guide through education, providing options, aligning our work with holistic multiple pathway approaches, evidence-based practices, trauma-informed care, recovery-oriented principles, but in a way that really honors choice and really honors what people are wanting for themselves, and to kind of step back and empower and help that to happen. I am out of time. I'm really looking forward to seeing any questions that may have come up and helping with responding to those. But I'll leave it to Rebecca and others to kind of take it from here. Thank you.
So much, Tim.
Go ahead, Jean.
Oh, yep. No, I was just going to say, if there's any questions, please put them in the chat. Tim, as of right now, I'm sorry, not in the chat, in the Q&A. As of right now, there aren't any questions in here. But thank you so much for your time. Great presentation. Loved it. Everyone who's still on the call, the slides will be posted on the website, and you should be directed or fill out the evaluation. Tim, thanks so much. This was wonderful. Rebecca, any last things?
No, I think we're good. Thank you for being here.
Thank you, everyone.
It's a pleasure. Thank you so much. Take care, everyone. Thank you for the work you do.